Thank you, Dr. David Dodgen Karthik, for the opportunity. Hi, Rex and Rajiv. So we're just going to talk briefly about the biomechanics of a modern reverse. Sorry, it's open already? Yeah, okay. Okay. Is that time different, or you have only 5 minutes or 10 minutes talk? Okay, so that's the Paul Grammant's reverse. He changed that failing design with the neck and the link to a large ball with no neck, which relies on the deltoid, and this is how it stays in place because of the large hemisphere, and then it moves because of the large hemisphere with no neck. There is no weakening point. Biomechanically, the center of rotation is medialized, making long lever arm for the deltoid. At the same time, lowering of a high shoulder, causing lengthening of the deltoid, essentially distalization. After Grammant's reverse, your arm will be lengthened by at least 1.5 to 2 centimeter. Because the center of rotation is medialized, the anterior and posterior parts of the deltoid will become recruited for elevation. That is why the post-reverse shoulder patient do effortless elevation. But at the same time, they lose internal external rotation component if the rotations are not restored. So very good survival rate, and the rate is increasing. I got trained with the reverse shoulder arthroplasty with these two people, three really, Dr. Akeland from Devil Day, Dr. Daniel Mock, all using Grammant's prosthesis design. I've just over 12 years experience in using this, and this is my number of reverse shoulder over the years, and I see the reverse shoulder proportion is increasing, becoming like 50% of all shoulder replacement, and a choice of first option rather than a salvage option. And this is my outcome of first 133 cases in UK with patient satisfaction of 99, and the right side is the complications in 185 cases in India. That's important to know because the complications are important. So dislocation used to be a big nightmare in the past when we started to do arthroplasty reverse, because at the time we were doing for salvage, but it is getting slowly removed, but it still happens. So here the patient's dislocated and is revised to a larger sphere. We will talk about the larger sphere. Size does matter in reverse shoulder. So that's a 2-year post-op. This is important. This is my patient who had a successful reverse shoulder arthroplasty, osteoporotic bone. She fell down 6 months later, periprosthetic fracture. This cannot be treated conservative. Whereas a periprosthetic fracture of an anatomical shoulder can be treated conservative, the reverse is not. Because he had to lift the arm, it doesn't work, so it had to be operated. So this is how she had a periprosthetic fixation plating, and which eventually healed. But remember, second operation. So scapular notching, we have been talking that for ages, which is a more hyped topic, but it does happen in a small proportion, and the clinical significance is not really known. But if we want to avoid big notching like this, these are all the various techniques we have been described in the past, but these things also getting modified. We'll see what. Acromion fracture is happen because of the stress and the tension, and if you operate on a younger patient like this. Following that Grammant's principle and my training, you had to do a preoperative planning to know where you can do this surgery safely. The green zone is safe. The other need more preparation. Familiarize with the system. Currently 4 to 5 systems are available in India. Each is different. The secular or elliptical base plate different. Central fixation different. And whatever you do, glenoid exposure is key. And glenosphere, in my practice, I just like to put the biggest possible. And the important screw superior and inferior with the tuberosity repair or posterior cuff repair to restore rotation. And finally, to check the stability on table to make sure this shoulder doesn't dislocate post-operative. Do all sort of movements to provocate dislocation. These are the principles in the regular Grammant reverse. We'll see a few examples quickly. 69-year-old lady, gynecologist doctor, 4-part fracture with distal humerus fracture. This is the nature of comminution. I decided to go for primary reverse shoulder here and fixation of the coronal shear fracture of the elbow. So that has been done now. And the patient had a reverse shoulder arthroplasty, and see the tuberosity fragments. He's got a good movement, and that is 1 year follow-up with good greater tuberosity healing around the reverse, which is better than trauma hemi. Another lady, 57, slightly younger, 2-month-old after treatment, hanging cause treatment. You will not be surprised. This is the nature of fracture, and that's the comminution, and that's the reverse shoulder done, and that is the repair as you see. This is a regular debut stem prosthesis, which is the original Grammant's design. It's not a fracture stem, but see the good integration of vehicle tuberosity, 3-year follow-up. And this is 56-year-old lady. I have performed a revision because he had already fracture fixation, failed. And this is the revision. That is a pre-op movement, unable to lift up the right arm. That is a forward elevation, and absolutely no rotation on the right shoulder at all. So here she had arthroplasty, 3-year postoperative, active elevation, and then you have, it's not playing. See the amount of external rotation and also the internal rotation. So this is possible in a regular Grammant. So why do you change? So this is the changes, lateralization, I think Sumant Krishnan is going to talk about. So the problem with the regular RSA is this scapular notching, which is hype topic or real, we don't know at the moment. Limited shoulder movement because of that. And second, the shoulder contour. If you distalize, the contour become puckered, and if you lateralize, it become a good contour. So you can do a metallic or bony, which I think Sumant Krishnan will talk about. This is an example of a graft. We just skip that and then concentrate on this one. The buzzling question is this: 135, 145, 155. Traditionally, we use 155 valgization, that is basically lengthening the deltoid. And this is the beautiful study by Devil Day and Akeland, which my teachers in reverse shoulder. They did this study, is a computer graphic study, which shows the lateralization effect of clearance of 15 degrees. Inferior tilt, very little, so we don't no longer do that. Inferior overhang, yes, much better clearance, about 30 to 38 degrees. And a thicker insert doesn't play much a role, but bigger sphere does play a role. So size does matter. 135 degree or 145 degree or 155. 155 is the original French Grammant design. 135 is the new German design. And in between, if you don't want to do, is 145 is the American design. So a few angles are there out here. 3D computer model study shows if you do a 135 degree, you get a near normal looking shoulder, normal shoulder contour, and we have a good range of movement. As proved here in a mechanical model, there is increase from 330 to 400 to 515 degree global arc of movement. But if you do a cadaveric study, it is not replicated, there is no difference in much rotation. But the 155 degree is found to be more stable because it's distalized, a large sphere, it just stays there. 135, because the mobility becomes unstable. So the real truth lies in between. So as the clinical study, systematic review of 65 studies with the 3,000 patients, there is clearly evidence saying that there is significantly more external rotation gain than 155 degrees. Number two, scapular notching was 2.83% versus 16%. So it is less. If you're worried about these two, you could go for 135 degrees. So effective humeral stem design, this is particularly the movement increase is the adduction, extension, and external rotation, if you're concerned about. So this is a very good study now showing all is not hunky-dory. So if you put 135 degrees, a beautiful paper from US, George et al., compare 3-angle 2-sphere 3 cups to check the maximum contact area versus maximum contact pressure. Both are different. So you look at the top, that is 155 degrees, you get a maximum contact. And if you look at this, the 135 degree had the bad effect of low contact and more pressure. So this is something to think about. It can cause damage. So 135 degree angle had a bad effect on this contact joint pressure, and a big sphere, whereas still has a good effect. So at the end of the day, we are coming to the same point of Grammant's design. So in my practice, I've just done few cases of 135 degree angle. This is a convertible orthorex prosthesis. You see the range of movement the 135 degree allows because it is like a natural looking shoulder prosthesis. So it's a 65-year-old man after a road traffic accident. The head is based in the axilla. We prefer to do a primary reverse shoulder arthroplasty for him. This is the base plate, inlay, elliptical, fixed, and then the 135 degree stem here. If you look at the post-op picture, it is more like a normal contour shoulder. So the contour of the shoulder, you see the line of the soft tissue is looking near normal. And I think the video is not playing. They do recover early range of movement. Okay, that's fine. So I met Dr. Anders Eklund here, right in Coimbatore for IOA Con, where he presented his beautiful paper on his long-term experience of operating over 1,000 reverse shoulder arthroplasty over the span of 2.5 decades. 300 of these were revision. These are his complication rate. And no patient will go lost follow-up in Sweden. So dislocation, infection, stress fracture, glenoid loosening, he's not bothered about that. He's bothered about humeral loosening. So compared to primary anatomical shoulder, the reverse shoulder in long run, the humerus is the weak point. So short stem is in OG. So I have done the first short stem reverse a few months ago. So for like this patient, I decided to use the short stem. It's a massive, just 30 seconds please. This is a primary arthroplasty with a short stem reverse, and that's the stem length. We don't need a long stem fixation in the proximal humerus for a reverse shoulder, and that's the result. So final word from Anders Eklund. I haven't done a single revision for scapular notching over 25 years. So are we talking about something which might not cause a significant problem? And he thinks that 135-degree and lateralization together sometime will improve rotation, reduce notching, but may risk a scapular fracture because you're putting too much tension on the system. So his concern at the time was, are we pushing towards a failure model of yesteryears? Only time will tell. Thank you very much. I'll use this opportunity to welcome you all to Elbow Conclave, where we have 8 UK faculty shoulder elbow surgeons are visiting Chennai. The focus is on elbow, arthroscopy, arthroplasty, trauma included in 2 weeks' time to come. All SESI members are free to register. Thank you very much.
A question to Dr. Ram.
Thanks.
Sir, a question if I can ask. So, Dr. Ram.
Yes.
Yeah. Questions.
Okay. Dr. David is ready. So the question here is that you, in your last slide, in the conclusive remark, you mentioned about lateralization and using the 135-degree angle. But the problem here is definitely long run, you have put more stress on the construct, because lateralization, by doing that, the center of rotation is no more at the base plate bone interface. It is slightly lateral to edge, and which eventually leads to the scapular implant loosening over the longer run. We have a bio RSA, and which we usually recommend for B2 glenoids. Why not, have bio RSAs in the routine practice, that is the bony increase offset RSAs?
I think I purposefully left about lateralization because Sumant Krishnan is talking about it. It's got a lot of experience and stuff in talk.
Yeah, there's going to be another talk on that.
Okay, separate talk.
No problem. Thank you.
But if you put a larger sphere, it does both components, like it does also lateralize, it also inferior overhang.